Good afternoon, everyone. Thank you so much for joining us for our READI Research Policy Impact Series. And before we begin, I'd like to tell you a little bit about the CTSC. The Clinical and Translational Science Collaborative of Northern Ohio is a collaborative among Case Western Reserve University and its affiliated hospital systems, the Cleveland Clinic, Metro Health, University Hospitals, and the Louis Stokes Veterans Administration Medical Center, NeoMed, and the University of Toledo. We aspire to be a catalyst for high-quality clinical and translational science and transformative research to positively impact the health of those in Northern Ohio and beyond. Today, this is how our flow will go. We'll have some introductions in the chat, so please feel free to share your name, where you work, what you do, and then we'll have a presentation from Dr. Baker. Now, Dr. Baker, if you'd like to share your screen, the floor is yours.
Thank you very much. Let me know when you can see that.
Perfect, thank you.
Great, well, thanks again for having me. I'm Executive Vice President and Editor-in-Chief at the Journal on Quality and Patient Safety for the Joint Commission. I actually have great connections to the Cleveland area. I was at Metro Health for 6 years working under Randy Siebel. And my focus throughout my career prior to coming to the Joint Commission has been disparities. So this topic is near and dear to my heart, and I appreciate the invitation to talk about the work that we've been doing. So today I'll go over our healthcare equity accreditation requirements for hospitals, ambulatory programs, and behavioral health. And I want to stress these are requirements to be accredited by the Joint Commission and for hospitals that are seeking deeming authority for payment from Medicare. They have to meet these requirements. But I'll also talk about our voluntary healthcare equity certification program for hospitals. We also have resource centers to help organizations meet these requirements. This is really a mission imperative for us. So we don't want to just set out requirements. We want to help organizations to actually meet those requirements. And then lastly, I was asked to say a little bit about the evidence base for the requirements. And that begs the question then, how do we develop requirements? So I'll say a little bit about that and we can talk more in the discussion. I want to stress at the start that the Joint Commission is not new to this. We have been working on equity for about 20 years. I won't go through all this, but a few highlights. We released the first standards related to this, focusing on provider-patient communication in 2010. And in 2011, we had a requirement to prohibit discrimination. And most recently, what I'll be talking about today took place in 2022 and 2023 for the accreditation and the certification requirements. So how do we develop standards? So we start off by looking at the literature. And we frequently will work with experts on the topic to help guide us onto the literature that's most important. This is a very broad review of the literature. We're not digging too deep into any particular part because, again, the standards are general. When I say standards, the requirements, those are general things for structures and processes that need to be in place. It's not down to the level of a specific treatment. We don't do peer review, for example. So it's broad research. And then we have input from a technical advisory panel. They're often advising us on what are the different domains that we should be looking at. You know, what are the most important issues that we need to be addressing? And then we'll develop proposed standards. Again, that's the term that we use for these requirements from that. And then we go out and we'll do field review testing, and we'll also go back to the technical advisory panel. And now we use more formal consensus techniques. And there has to be at least 75% agreement with the technical advisory panel. And the majority of the time, since we've been doing this over the last year and a half or so, The majority of the ones that we release have near 100% consensus on. And I won't go through the rest then. It's that process of the wordsmithing and all of those other challenges, and then pre-publication. And then as part of that process, if people are interested in learning more about this, I'm not going to go through this today, but for every set of standards we release for accreditation, we have what's called an R3 report. What's the requirement? What's the rationale? And then some selected references, not a comprehensive review of the literature, obviously, to give people an idea for those factors I just mentioned. And I'll be happy to circulate the slides. This is the one just to give you an example of what we'll be talking about today for health-related social needs, the rationale and a few of the references. So that's the thinnest possible explanation of how we develop our requirements, and I'd be happy to talk more during the discussion. So for the accreditation requirements, as I mentioned, these are applicable to hospitals, selected ambulatory care programs, not all. We have a wide variety of different groups that get ambulatory accreditation, and behavioral health. We implemented the standards and what we call elements of performance, which is most of what I'll be talking about today, originally in January of 2023. So the broadest term that we use is requirements, and then we have standards, which are general statements around quality and safety. And the elements of performance are really where the action is, because remember, we have surveyors come into organizations and they want to look and say, is the organization meeting the standards? So they look and say, are they meeting those elements of performance? So that's what the surveyors really look at to say, yes, they're meeting the standard. So in this case, the standard is simply that healthcare equity is a strategic priority for the organization. So how do they know that? The first is that they've designated a leader. This is fundamental really to any quality and safety improvement activity, is to have one person or two. It can be more than one person, but you have dedicated leaders for pushing that forward. The second element of performance is assessing health-related social needs. Now, for the accreditation, this doesn't need to be for every patient for all health-related social needs. We just wanted to get organizations starting down that pathway and understand how to do this, because they will need to do this routinely in the future because of pending Medicare, CMS quality measures, performance measures. So assess health-related social needs and then address those, have systems in place for addressing those. And then stratify quality and safety data. It's very important. All these organizations, they've got quality measures that they're reporting, and many for over a decade, places that I've worked before, they routinely stratify by gender, perhaps by payer status, by race, ethnicity, et cetera. So organizations need to do this to look for disparities. And if they see disparities, that leads to EP4, which is creating an action plan for addressing these. Excuse me one second. And then over time, over years, when they come back, they have to show that they've actually been able to meet that action plan, that they've made progress, otherwise they need to make changes. And then the last element of performance is to keep stakeholders informed. So for these, we have this Accreditation Resource Center, which I mentioned previously, and this is just a screen snapshot from one of the home pages about this that you can go to. It's all publicly available. And the way we set this up, you've probably seen these resource centers before that are just overwhelming. So we try to select things that we talk about a curated resource center. It's not comprehensive. It's designed to have what we think are the most useful materials. So some of those can be, excuse me, snapshots. So these are brief synopses of what organizations are doing, leading organizations. Sound bites, so videos of organizations' lessons learned, and strategies. So these could be toolkits, templates, and guides, etc. And we set this up very simply according to the elements of performance, which you see here. So if you want to look for health-related social needs, you can just click on this and drill down into it. And then there's one that's cross-cutting here that I'll talk about more, evidence-based interventions. So I'll just show a couple of things. This is one that's been very popular. This is a toolkit for health-related social needs. So it shows the 5 tools that are the most widely used in the customers that we talk to or the healthcare organizations that we accredit. And it goes into a deep dive, and you can look at this by the tool. You can look at this by individual questions. So if you want to say, I just want to look at food insecurity questions, you can click and you can drill down on this. So this has been very useful. And then, as I mentioned, the evidence-based interventions, the team has looked through the literature, and this is something that continues to grow. And to be put up on the website, it has to have been published in a peer-reviewed journal, has to have a randomized controlled trial methodology of some kind, and conducted with adequate sample sizes, well-defined patient population, and very importantly, the study is replicable. We'll see some studies that were funded externally, some by grants, some by charitable donations. That one in particular that I saw, it was over $1 million grant to be able to do the work. Well, that's probably not reproducible at other places without external funding. So that's the type of study that may not make it in. And these are searchable, so you can look for the specific clinical topic. You can look at the type of intervention that was used. And hopefully, again, this will be useful for developing those action plans to address equity. So I'm going to pause at this point and just see if there are any clarifying questions. Jaleese, if you can let me know. I can't see the chat, so let me know if there are any clarifying questions. Okay. Can you hear me okay, Jaleese?
Yes, you're good to keep going. Thank you, Dr. Baker.
Great. I just wanted to check. So we've talked about those accreditation requirements, and as you can see, these are really basic things that organizations should be doing. I think about healthcare equity. It's a quality and safety issue. It's a social justice issue, but this is similar to what you would do with other quality and safety issues. If you were looking at hospital-acquired infections, you'd look at your data, you'd stratify your data. You'd look to see, are there groups of patients who are not getting the care they need, or they have higher complication rates, et cetera. And then you drill down and you look at your root causes, right? This is quality and safety 101 from my perspective. Certification is quite a different level of commitment to this. So this is a very rigorous certification program. And why would an organization want to get this? So there are many organizations, including ones that have helped us develop this program, that are very advanced. They've been working on this, for 10, some even 20 years. So they want recognition. They want to recognize that they have a robust set of structures and processes designed to achieve equitable care. And it's a symbol of pride for their staff, for their leadership, for their patients, and for many, it's actually important for the community. The community want the community to know that they've had an external organization come in and look at this and verify that they're not just talking about this. They've got structures and processes in place. The other thing that's very important, as I mentioned, this is a mission imperative for us, is to provide a roadmap that others can follow to advance equity. Many organizations really will not be able to meet certification, at least in the in the short term. They won't be able to meet all of these requirements. However, with the standards as goals and the resources as tools, they can slowly and steadily move on this journey. So let's say we want to work on interpreters. We want to be able to work and address the issues of people with disabilities. So they can look and hopefully continue this journey. And at some point, it would be wonderful if they could actually complete all of these and apply for certification. But our goal really is with this is to help move the field forward. So there are 5 domains, broad domains with multiple things beneath those that compose the requirements. So leadership, collaboration, data collection, provision of care, and performance improvement. And I'll just give you some examples of these. We have a short period of time today, so I'll just go through some examples. And I will mention that we have a similar resource center for healthcare equity certification that you can go to. Again, this is open, it's publicly available. So for leadership, the key thing that's different from accreditation requirements is board review and approval of the strategic plan. That is so important for the success and the continuation of efforts in the area of equity that to be certified, we thought that that was very important. And again, I'm just going to touch on some examples for these. The second is critical is collaboration with patients and communities. So the requirements, the organization collaborates with patients, families, caregivers, and community organizations to support healthcare equity. So some of this, for example, for the patients that they're seeing, you want to understand the experience that they're having. It may be a patient family advisory group. It may be through experience of care surveys. We heard from our technical advisory panel, there are just multiple ways of doing this. So we're not prescriptive in what needs to be done. But it's also important to look at the community and understand community level organizations, what they're doing, what their needs are, how they can particularly help with health-related social needs. So that's important as well. Some of this can be done through the data that organizations already collect for their community needs assessment, for example, for their not-for-profit status. And again, I'm not going to go through these, but these are examples of some of the resources that are available that talk about how to collaborate with the community and true partnerships. So I use the word collaborate, but you know that's kind of old language that I slip back to. We're really talking about partnerships. In terms of data collection, that should really be done at the community level, at the patient level, and staff and leaders. So for the community, organizations, we heard this from the technical advisory panel, is really interesting that, you know, you can't just talk to your patients because some parts of the community may not trust the organizations and they're not seeking care. So you need to engage the community to understand about the reputation. What is the organization, what's the healthcare organization doing to help address those needs of the community? One thing frequently, communities change over time and you have new groups moving in and you have new language needs, for example. So it's really important to have accurate engagement, but also to get the data from the community and the health-related social needs in particular. For patients here, we talked about some of the requirements before for accreditation, but it's much more extensive for certification. Here, the organization should be collecting the usual things, race, ethnicity, and preferred language, but especially health-related social needs, physical, mental, communication, or cognitive disabilities that require accommodation and the accommodation needed. So this is really a first. It really pushes the field forward in terms of meeting the needs of people with disabilities. And interestingly, again, the technical advisory panel felt very strongly it's important to assess incidents and perceptions of discrimination and bias experience by patients. We have talked with Press Ganey, and Press Ganey has been experimenting with different questions about how do you ask the questions about perceptions of discrimination. So there's no standardized instruments for this, but we think that this is something that the field is definitely ready for. In terms of health-related social needs, these are supposed to be collected routinely, not just on selected patients like under accreditation. You can't do it for all patients, but at a minimum, they should be trying to do this for all patients. Difficulty paying for prescriptions and medical bills, food insecurity, housing instability, interpersonal safety, transportation needs, and utility difficulties. And these map fairly well actually quite well with the CMS requirements. The one thing that I'll point out here is that is not part of the CMS measures is difficulty paying for prescriptions or medical bills. And I think that is one of the most critical things that organizations need to be screening for, because then if you can identify these people, then they can be tying into the ability to pay plans. I've mentioned the importance of collecting data for people with disabilities, and I will hold off on saying anything else about that because of time. We do have resources. There's been quite a bit that's come out, some of which we published in the journal about how to collect disability information, as well as what accommodations are needed. Refer you to the journal for a really nice article from about 4 months ago on collecting disability information and accommodation needs. It's also important to get data from your staff, race and ethnicity information, the languages spoken, and as well incidents and perceptions of discrimination and bias experienced by staff and leaders to understand what they're experiencing. In terms of provision of care, there are 5 areas here that I'll go through. The first is the organization should really be working to address the recruitment and retention of staff and leaders so that the staff and leaders reflect the diversity of the community and the patient population. The organization also needs to be providing education and training on a number of things, particularly the collection of patient-level data. How do you do that in a sensitive way? Particularly health-related social needs can be, it's a source of shame. And we have some very nice materials in the Resource Center from organizations that have formal training programs to teach staff how to ask those questions in a sensitive way. And also training about how do you work with interpreters, using auxiliary aids for communication, hearing aids, etc. So these are all critical. Then qualifications for interpreters. Addressing health literacy needs is particularly challenging, but we think that that's important for organizations to at least be thinking about that. And here the organization addresses the health-related social needs of patients. So collaborating with community social service organizations to address the health-related social needs. Ideally, this is a closed loop and you're getting feedback. That's the big next challenge in this area, is to be able to find out which patients are actually getting their needs met. But quite a bit more work needs to be done. There's some good demonstration projects on that, but that's particularly challenging. So I will stop at this point and just say again, you know, we see this as a journey, and it's a long journey. As you can see, I just tried to give you a broad overview of the certification requirements, what's included in that area, but it's so complex. You're trying to meet health-related social needs. You're trying to address language access, including for American Sign Language, still major problems with that. Access to care for people with disabilities, still major problems. So we just want people to start on that journey. I hope that that gives you some good food for thought for your own organizations about how you might address the needs of the patients and work towards healthcare equity. So I will stop at that point and be happy to take any questions.
Thank you very much, Dr. Baker. If anyone has questions, you can place them in the chat or feel free to take yourself off mute. I see very helpful information. Thank you. I can start with a question about research, translational science, and where you might see a role, or what role do you see translational science playing in elevating how an institution could gain health equity accreditation from the Joint Commission?
So translational science, this is, if I recall my translational science terms, this is sort of, we're at the T3 point, right? How do you take these concepts and really be able to test them out? So for example, the meeting health-related social needs, there's a tremendous amount of work that needs to be done to understand how can you actually get people to the community resources, get that information back, complex information sharing, lots of implementation challenges in that. We know it's possible, but how do you do that at scale? And similarly, for accommodating the needs of people with language, interpreter use is something that I've been interested in for over 30 years. Right at the start of my career, I trained and was on faculty at UCLA, and huge language needs there. And I think there's been major advances in the use of technology, a number of other things, certification of staff, that they have competency in a specific language. So again, how do you take those principles and actually first meet the implementation challenges so that you do that well and with high fidelity, but then also how does that affect outcomes? So those are all of these topics. You can go down the list. And then there's also, again, with our certification program, we always say we certify organizations, right? So we're looking at these broad issues, but then there's the deep dive on clinical issues. So for example, I used to run the Center for Reducing Disparities in Use of Preventive Services. We were funded by ARC when I was at Northwestern. And my focus was on colon cancer screening. And my focus was particularly on how do you improve colon cancer screening for Latino patients, low income, under-resourced communities, language barriers. And so I led a randomized controlled trial of, how can we do that at scale using text messaging and a variety of different tools to try and get up. And we got, 85% screening rates within that. So that's the other type of research that needs to be done. Vaccination messages. That was another one of the arms of our center was on communication around vaccination, pneumococcal vaccination, influenza vaccination, et cetera. Cardiovascular disease prevention, that was another arm of our center. So all of these are just great topics for translational research.
Thank you. Now we have another question from the Q&A. How do you coordinate data collection and information sharing in a place like Cleveland with multiple large healthcare institutions?
Yeah, that's one of the biggest challenges right now. And when I was chief of general medicine and geriatrics at Northwestern here in Chicago, and we faced a similar challenge that I would have a patient that may be going to rush for the orthopedic care or getting their cancer care at University of Chicago. So there you get into large scale data sharing, and that's outside of my area of expertise. I think that there has been some progress made, but still tremendous challenges. Many of you, I'm sure, are on Epic, and they have the Care Everywhere system, and that's been helpful. But it's really, we still have a long way to go to be able to understand this. And it's important for the clinical aspect, but also you think about if somebody's going to 4 different systems, does everybody need to screen for health-related social needs and refer people on to these community organizations to get those needs met? It's going to be totally overwhelming if we can't figure out a way to coordinate that. So I know there are a number of people around the country who are working on that, but it's not an area of expertise of mine.
Thank you. Do we have any more questions, comments?
I'm curious, could you talk a little bit more about the randomized controlled trial with the text messaging and how that worked and how you got to an 85% success rate?
Sure, and I'd be happy. It's all been published, and if you send me an email to dbaker@jointcommission.org, I can send that to you. And there are other really nice studies to look at as well. So this is something that we had probably been working on for 10 years. We've been looking at communication barriers. A lot of our work at Northwestern was on health literacy and communication. And we started off the way I think always needs to be done, by understanding what are the root causes. You know, that people aren't getting reminders because their clinicians are too busy. They don't understand how to use they were at the time they were getting, using the FIT testing. If you're familiar with the colon cancer screening, the immunochemical tests, it's challenging to use. Look at the instructions that you get with those. So we had to develop our own low literacy instructions. And we basically, that's another one of the papers that we published, is here are the root causes. It's sort of a theoretical model for the intervention. If I recall, there were about 7 different areas. Going down to the last one was putting a stamp on the return envelope. It was down to that level because we knew that that was a problem, right? It's a problem that sometimes people didn't have any stamps and they would forget about it. Sometimes they'd do the test and that was the last thing, and it would sit around for 2 weeks, and then it's going to be a false negative, right? So that's what I would really encourage people, whether it's a general quality and safety issue or whether it is a specific issue around equity. Start off, understand the root causes, deeply understand the root causes, work on those interventions. And then the way we did the randomized controlled trial was easy. We could query the electronic health record and identify everybody who met eligibility criteria who had not been screened. And then we got a waiver from the IRB for the need for informed consent, because we were trying to provide something. It wasn't experimental, right? It had already been approved and it was recommended for this population. And then we randomized patients to receive either it was a text message, it was a telephone call, it was a whole variety of different things. And that's how, I mean, honestly, we were amazed. We built into the system an interim analysis after 1 year in case it was really successful. And we far surpassed that. So we stopped what was supposed to be a 2-year trial. We stopped after a year and we rolled that out to the control group. And the vast majority of the control group had not been screened in that year. And they were still eligible. And then we received very good results, and good results on repeat screening as well. So we were able to continue it, not in the randomized fashion, because again, we thought it was unethical to continue to do that. That was it in a nutshell. I will say, the challenge was getting people with positive tests to get the colonoscopy. There was I think it was like 55% ended up getting it. And then when we started looking at the literature and talking to other groups around the country, that was a common problem. And again, okay, now what's your root causes of this? It's like, well, they have to come down to Northwestern. They have to have parking because, the community clinics that we were working with didn't have that capacity to do that on site, right? So that's still, and again, I haven't kept up with this. I've been at Joint Commission now for 9 years. I don't know that literature really well, but I don't think that problem's been solved. I have seen other reports of low rates, but that's the challenge for doing this kind of research. You know, you solve one problem and then you realize you still got others, but that's, you keep pushing forward.
Thank you so much. That's really interesting.
I can see the chat now if you want me to just go through questions, Shalise.
Yeah, I'd be happy to read it aloud too.
Okay.
Yifan says, I'm glad you mentioned outcomes with limited available and accurate data. Is it possible to coordinate with multiple health and social organizations to standardize the data collection and enhancement process?
Great question. So we've had a lot of discussions the last year and a half or so of whether there should be standardization of this. And the arguments are, well, first, we don't know the right way to do this, or we don't know the best way to do this at this point in time. So we shouldn't standardize. And that's where we had a group that was working on this with National Quality Forum and NCQA. And, you know, as soon as we kind of settled on that, then we said, we started hearing these more and more challenges. So even though it hasn't been standardized, I think that in the next couple of years, the way the questions are asked or the specific questions ideally need to be standardized. There's also the technical aspect of how do you standardize in the electronic health record what those questions were and what the responses are. So that's something that I think they have made progress on, but it's still a real challenge. But I agree that, you know, there's going to have to be standardization. Now, the focus that's driving standardization, unfortunately, is sort of the accountability, right? These are going to be publicly reported, so we want to be able to compare apples to oranges. I think that's misguided. The goal is improving care and patient outcomes, and to do it in a way that is sustainable, because that's one of my biggest concerns is if we don't make this easy for organizations, then people are going to say this is too hard, there's going to be backlash. And as a clinician, you know, some of these things I need to know if I'm trying to treat somebody's chronic medical problems and they can't afford their medications, I need to understand that. There are other medications I might put them on that are cheaper. If I have a diabetic and I'm trying for reasonably tight control and that person has food insecurity and sometimes won't be able to eat, that is a really bad idea, right? To go for tight control in somebody who has food insecurity. And I could go on down the line. I mean, you know, you have somebody understanding that you're caring for somebody who is a strict, follows Islam during Ramadan and fasts. Again, you know, all of this information has clinical importance. Some of it as well, you know, it needs to be addressed going outside again to get those social needs met. But they have that clinical importance again. So, you know, we need to find ways of doing this effectively, efficiently, so that we can get patients to have those better outcomes. Measuring that, that's a tough research project. I think I've rarely been afraid to take on hard ones, but showing that outcomes actually improve if you address health-related social needs is going to be really tough. So next question, having worked at a hospital association, the COVID-19 was a game changer in so many ways for hospitals and healthcare systems. How did the pandemic change the way the Joint Commission works with healthcare systems? That's a good question. I don't think, I mean, COVID changed things in so many ways. we had to stop doing surveys around the world because we're in 70 countries around the world. So, we had to shut down operations. We're coming up on the 4-year anniversary. It's hard to believe. And then we started doing virtual surveys. We couldn't do those in all of the hospitals because CMS would not allow us to do that. But we learned a lot about virtual surveys. And we're continuing to pilot ways of sharing data so organizations can share data before the survey, save time during the survey process, et cetera. So we're looking at a variety of things that we had to do during the COVID period. And then now, which of those would be beneficial for us and the healthcare organizations that we accredit to be able to do going forward. The challenge in this, though, is CMS is reluctant to have the Joint Commission do things that like state agencies, survey agencies don't do. So it's tricky, but we're definitely looking for those opportunities. But fundamentally, for the most part, things really haven't changed. They're pretty much back to normal now, except, like I said, looking for innovations that we can implement. Okay, I don't see anything else, Jaleese.
All right. Well, thank you so much, Dr. Baker. We appreciate your time and insights. And as Dr. Baker said, the slides will be made available through email. We'll send those out after the call. And if you have any questions, his email address, dbaker@jointcommission.org, is in the chat. Thank you so much for joining us this afternoon, everyone.
Bye.